Hi, and welcome to my presentation, Improving Diagnosis, Improving Outcomes, an intervention study for complications of Kawasaki disease. Kawasaki disease is the leading cause of acquired heart disease in children in the U.S. It is defined as a self-limiting febrile vasculitis of unknown etiology that primarily affects children under the age of 5. It is characterized by fever, rash, swelling of the hands and feet, irritation and redness of the eyes, swollen lymph glands, irritation and inflammation in the mouth, lips, and throat. Serious complications include coronary artery dilatations and aneurysms, which is shown on the right, heart disease, myocardial infarction, and even death, which approaches 1% in untreated cases. Though a rare childhood disease in the U.S., Kawasaki disease can have severe sequelae due to high prolonged fever, inflammation, and other immune response pathways. There's no way to prevent KD, but treatment with intravenous immunoglobulin with high-dose aspirin is known to significantly lower risk of developing coronary artery abnormalities, or CAAs. Sometimes steroids or arthritis medication are also given. Incidence in the U.S. is estimated at 10 to 17 per 100,000. There is a greater risk for CAA development in untreated cases, greater than 20%, while only 5% for treated cases. The population groups most affected by KD and its resulting CAAs are those of Asian ancestry at a 32.5 per 100,000. Males make up 60% of cases, and children under the age of 5 make up 80%. A retrospective study in the US published in 2000 showed a median hospital cost for children at greater than $6,000. I'm sure that this has increased over the last approximately 15 years. Incidence rates have risen over the years since its discovery in 1967, but mostly due to the improving ability to recognize cases. There are genetic and environmental risk factors for CAA development. Genetic includes age of less than a year old. Aneurysms are especially significant in that group. Asian and Pacific Islander heritage is also, again, a risk factor, and those who are unresponsive to IVIG therapy as well. Those who do not receive treatment or receive treatment late also have a higher risk. Late diagnosis and treatment is defined as occurring after day 10 of illness. So far, most studies have focused on investigating variations of treatment for IVIG unresponsive patients, and these have been partially successful. Moreover, even if the genetic factors are understood, developing preventative measures in regards to them is quite complex and likely more down the road. Therefore, at this point of understanding, our efforts are best spent on decreasing the risk of KD-related complications due to late or no treatment. Therefore, our target risk factor is earlier treatment, which is really influenced by quicker diagnosis. Some of you may chuckle at this picture, but even if you don't recognize the reference, the statement is definitely true. One does not simply diagnose Kawasaki disease. That's partly because diagnosis is completely clinical right now. It has to meet the case definition of having a fever of greater than 5 days plus 4 of the below symptoms. Otherwise, it is categorized as atypical or incomplete if coronary artery abnormalities are already discovered. In a study published in 2005, researchers decided to investigate delayed versus early diagnosis in their state. They found a very significant difference in coronary artery aneurysms between what they defined as a delayed diagnosis group, or DDG, versus an early diagnosis group, EDG. Though the p-value was not quite significant for coronary artery abnormalities, the researchers believe this is due to the small sample size in the DDG group, which was only 25. As noted, they believed it may not have been large enough, and a larger size would show a difference more significantly. As well as calculating relative risk, the researchers diagrammed when certain symptoms were occurring between the two groups, A being the EDG and B being the DDG group, or delayed. You can see that the characteristic symptoms are clustered together for group A, while in figure B, they are scattered and delayed throughout a much longer period of time. You can notice when the patients were brought in by their parents at a later stage as well. And the researchers, in their conclusion, determined a diagnostic test for Kawasaki syndrome is needed to identify these children earlier. In response to this difficulty, another group of experts used data from a 10-year period to develop an algorithm to aid physicians in diagnosing KD cases. They used clinical and laboratory parameters, which are all commonly used at this time, but put together to generate a KD score of one of three possibilities: low, intermediate, or high. The low indicating non-KD status, while the high indicating likely KD status. Their initial training and testing evaluations had high success, as shown in the 95% NVP and PPV respectively for low and high. Therefore, this intervention study objective is to test the effectiveness of this new diagnostic algorithm for improved outcomes in patients with Kawasaki disease. First, 1, in decreasing days to diagnosis, and 2, in decreasing the CAA incidence through earlier diagnosis and treatment. The study design and methods include a community-based or hospital-based prospective study. Participating hospitals throughout the U.S. will be randomized to either incorporate the new algorithm score in their diagnosis decision, being the test group, or use their current methods, being the control group. Test and control groups will be stratified by hospital type to mitigate confounding caused by physicians' previous level of experience with KD. This would be stratified by pediatric versus general and urban versus rural. All KD suspect cases will be evaluated similarly within a hospital, with all relevant staff trained to use the diagnostic aid in the test group. And please note, this algorithm will not replace but supplement the current methods and experience. After diagnosis, suspect cases are defined for analysis purposes as complete, atypical, or non-KD, and that is using the case definitions. Diagnosed cases, complete and atypical, are then categorized by symptom presentation. Day 1 is the first day of fever. Early presentation group, or EPG, will have at least 4 of the 5 criteria by day 5, and the delayed presentation group, or DPG, will have less than that by day 5. Again, referring to the figure, you can see that by day 5, group A, where those who are diagnosed and presenting early have the fever plus 4 well within day 5, and group B, or the delayed diagnosis group, presents with only, on average, 1 extra symptom by day 5. We had to switch the definition because we're trying to decrease the diagnosis time, and therefore we have to have a similar but different definition to distinguish between groups. Continuing on, all hospitals will be enrolled prior to the testing phase, which will be for a full year. A follow-up period for each patient will last 4 months to capture CAA development status. All hospitals will have records retrospectively analyzed from the baseline period, which is the year previous to the testing phase. Hospitals randomized to the test group will be compared to hospitals in the control group using chi-squared, Fisher-exact test, and t-tests, and hospitals in both groups will have baseline period and testing phase data paired for analysis using paired t-tests. The key measurements by hospital will include incidence of KD cases, incidence of CAA development, mean day of diagnosis of KD cases, as well as the proportion of KD cases diagnosed after day 10, DDG, the proportion of CAAs in that group, and the mean day of diagnosis for that group and the earlier diagnosis group, as well as similar measurements for the DPG and EPG, or presenting groups. The strengths of this study include having several hospitals stratified by type to yield a more powerful result than previous evaluations of the diagnostic algorithm. Also, randomizing by hospital rather than patients avoids confusion among the physicians and patient families within a hospital, as well as being efficient in costs and time. A year-long and unified testing phase period will mitigate bias due to KD seasonality rates. The design will also yield insight for further understanding of atypical KD and possibly IVIG responsiveness characteristics. Limitations could be in the records for the baseline period, them being incomplete or inaccurate. And though we're stratifying, differences in KD incidence per hospital due to the testing phase could vary in a higher degree than expected and bias the analysis. Also, different levels of trust toward the KD diagnostic algorithm score may exist among different physicians and hospitals, which could also bias the analysis. What do we expect to see? We expect to see a decrease in mean days to diagnosis, as well as a decrease in proportion of DD cases in the test group as compared to the control group. We hope to see decreases are similarly expected in paired analysis of change by hospital. We expect the incidence of CAAs per hospital to drop for both test to control analysis and paired hospital change analysis. Also, the projected study duration will be 2 years, enrollment period being about 6 months, testing phase for 1 year, and follow-up and data analysis taking another 6 months, 4 months of which is part of the follow-up. And with that, we hope to achieve improved outcomes through improved diagnosis and using a new and improved diagnostic algorithm. Thank you for your time. I'd also like to refer to the references I've made in the presentation, and I hope you have a good evening.